Thank you everyone for joining us tonight. What happens in the gut and microbiome has a huge impact on our patients' overall health and wellness. Understanding how to assess and treat gastrointestinal imbalances is the cornerstone of your patient's well-being. Tonight, Dr. Jill Carnahan presents clinical cases for difficult-to-treat patients. She'll be presenting new protocols you can implement into your practice immediately. Dr. Carnahan completed her residency at the University of Illinois program in family medicine at Methodist Medical Center. She received her medical degree from Loyola University Strick School of Medicine in Chicago and her Bachelor of Science degree in bioengineering at the University of Illinois. She is dually board certified in family medicine and integrative holistic medicine. In 2008, Dr. Carnahan's vision for health and well-being resulted in the creation of Methodist Center for Integrative Medicine in Peoria, Illinois, where she served as the medical director for 2 years. In 2010, she founded Flatiron Functional Medicine in Boulder, Colorado. She recently opened a brand new medical clinic with a broad range of services in Louisville, Colorado. She is committed to teaching other physicians how to address underlying cause of illness rather than just treating symptoms through the principles of functional medicine. She is a prolific writer, speaker, and loves to infuse others with her passion for health and well-being. Due to the large audience tonight, please use the chat option to submit questions, and we will address them at the end of the webinar. Dr. Carnahan, thank you so much. I will turn the webinar over to you.
Thank you, Lindsay, and welcome to everyone who's joining us tonight. I know I value your time because there's so many other things you could be doing, but we're going to pack into about 30 minutes two incredibly interesting cases that we will hopefully have some very practical application for you, like Lindsay said, right away, and then we'll leave some time for Q&A at the end. So please put in your questions. Lindsay will take those, and then we will address those at the end. So let's get right into the program. I always mention when I'm speaking, if you are interested in receiving some of the latest research, I do a free newsletter, and it's the link is on my website under about.com for practitioners. It's for doctors only, and it's only every 2 months. You get just a newsletter. It's free, and it just contains research on the gut, the microbiome, and all the stuff we're talking about. Okay, so case number one. Case number one is a 17-year-old male with Crohn's disease diagnosed approximately a year prior to when he first saw me. His history included that he was born by a C-section early in life. He spent a lot of days in the NICU. And the significance of that is the microbiome is really critical at birth, and the breastfeeding versus bottle feeding, C-section versus regular vaginal delivery has a huge impact on the microbiome. For example, babies who are born vaginally have much more lactobacillus and bifidobacter species, and babies born by C-section may have enterobacter, staphylococcus, and other types of skin flora colonizing their gut from early in life instead of the normal bifidobacter predominant in babies. So this can be a significant issue. Zantac for the reflux that he experienced, and of course that will inhibit hydrochloric acid production in the stomach and also affect the microbiome. And then frequent ear infections and many antibiotic courses early in life. So he was set up from birth to have a dysbiotic microbiome. Okay, so prior to seeing me, for the past 5 years, he had had off and on diarrhea and anal fissures. He had had hemorrhoids, heartburn, and abdominal pain. And he saw. Lindsay, can you hear me? I think I might have got off the.
No, you're good, Dr. Carnahan. Sorry about that.
Okay.
Go ahead.
Okay, excellent. So prior to seeing me, he had this much worse symptoms. He ended up getting a scope which showed Crohn's disease. So here he came in with his diagnosis, and he had, interestingly, with his mother's help, started the specific carbohydrate diet, the Elaine-Gottschall diet, and he had actually become almost symptom-free prior to seeing me. But in March of 2015, he had a ski accident and had a mild concussion. And again, I bring this up because it's very significant that head trauma and traumatic brain injury can have a profound impact on the motility of the gastrointestinal tract. And because of that, it can predispose to either flares of IBD, or it can predispose to things like SIBO, or small intestinal bacterial overgrowth, or all kinds of other dysbiosis. There's also evidence to suggest that traumatic brain injury increases permeability of the gut. So if you're aware of that in the history and you notice, they had either multiple concussions through sports or a specific incident, you definitely want to look at the gut as a piece of the puzzle, because the brain and the gut are so intricately connected. So he presented to me 2 months after concussion, and all of a sudden his Crohn's disease symptoms were back in full force with weight loss, diarrhea, abdominal pain, and fatigue. His doctor, of course, suggested Humira, and he did not want to go on that, and that's why he came to see me to see if there was any other option before he needed to have this immune modulating drug. So he had on his own, because of the success of the original SCD diet, went back on that diet, but this time it didn't totally resolve his symptoms. And of course I'll give you the answers that I did, but I'd like you to just think before I click the slide of what you might do, what kinds of testing you might do, and what kind of treatment you might do. I would say I tend to see a lot of Crohn's and colitis and IBS. I see a lot of gut issues. That's a particular area of interest of mine, and part of it is because I'm a 14-year Crohn's survivor, and I'm in complete remission through functional medicine, so I have a personal experience with this. But it's real important to think about how would you approach these patients. I would say the absolute essential would be the testing, like stool testing and checking the microbiome, and you can see that on my plan. So what did I do? Initially I gave him a multivitamin. I gave him a D vitamin. The reason for that is fat-soluble vitamins are often impaired due to malabsorption in the small bowel in these kinds of illnesses, so you want to make sure they have all the essential fatty acids in the fat-soluble vitamins, especially vitamin D3, because there's multiple studies correlating increased survival and better outcomes with vitamin D in IBD and inflammatory bowel diseases. Curcumin is a potent anti-inflammatory, and I almost always will add this for inflammatory bowel disease at a pretty high dose. If tolerated. Ginger is very good for nausea, and that was a particular chief complaint when he came in. So I don't always use ginger, but I do like that for nausea. Glutamine can be healing to the enterocytes, and while we're waiting on testing, I started him on that. Due to the dehydration and diarrhea, I added electrolytes, and there are several high-dose probiotics that have been studied in inflammatory bowel disease, so I usually start with those as I'm doing the workup. He had been on Lomotil, Zofran, and prednisone because of the flare, and I recommended a continued SCD diet. Usually with the Crohn's and ulcerative colitis patients in a flare, I will recommend well-cooked foods, broths, vegetables, smoothies, things that are partially digested so that they can kind of take a break with their digestive tract. Usually I recommend no raw fruits and vegetables until they start to heal. And we took him off the top allergens, gluten, dairy, egg, sugar, soy, and corn. And then you can see the testing I ordered, and I will show you some of the significant results from that. So the stool test, as you might imagine, had calprotectin elevated. Calprotectin is a very well validated stool marker that shows inflammation, and it can be correlated to flares of Crohn's and colitis. So we use that if it's greater than 200. This one happened to be around 250, so very, very high. It was definitely in the midst of a flare. And if you want to follow your patients as they go into remission and stay there, you can see the calprotectin will go below 50. So frequently, if we're worried about someone getting worse, I will do sequential stool calprotectins, which can be done through any regular lab, and follow that for either flare or progression of the disease. You can also see pancreatic elastase was a little low. That's enzyme and suggestive of pancreatic insufficiency. Here's the actual number. I'm sorry I quoted that wrong. It was 174, not 250, but it was high. Irregardless, it was above 120. And here you see that low pancreatic elastase. Often that is in the presence of small bowel overgrowth or inflammatory changes in the small bowel. Those microvilli that are damaged will feed back on the pancreas and cause pancreatic insufficiency. So these things commonly go together. And part of the treatment protocol would involve pancreatic enzymes, because if you do not have that patient digesting food completely, it's going to feed that excess bacterial or fungal overgrowth and cause even more problems. And then this was the culture, and you can see the stool was positive for Klebsiella, and that was the most significant potential pathogen. Strep species, this is just clinical experience. This is not validated by a randomized controlled trial, but I frequently see high levels of strep when there is small intestinal bacterial overgrowth. Common species for SIBO would be strep species, Enterococcus, and Klebsiella. So because I'm seeing those, I'm also suspecting small intestinal bacterial overgrowth as well. Now, just to make this very clear, a stool test will not be able to tell you if a patient has SIBO. So what I'm telling you is just things I see in clinical practice that often correlate, but if you want to diagnose SIBO, you need to do a breath test, a lactulose breath test, where you measure both methane and hydrogen, and that's diagnostic for SIBO. So this is just the sensitivity for the Klebsiella. And this is organic acid testing, and you can see as well, number 41, there is high, that's a bacterial metabolite, so this correlates with a bacterial issue in the gut. And this is important as well because sometimes patients can also have fungal overgrowth, SIFO, at the same time, and that would, rabinitol would usually be high in that case, and then you would want to be more cautious about using antibiotics so that you don't cause a problem with fungal overgrowth. In this particular patient, it appeared to be a pure bacterial issue. So what did we do? We gave him ciprofloxacin and metronidazole for 10 days. We weaned his prednisone. We added the pancreatic enzyme. We added A to the vitamin D. Those two synergistically allow healing of the microvilli. Zinc is critical when there's inflammation because lactoferrin and calprotectin excuse me, will both use up zinc. Adrenal support and DHA are helpful in autoimmunity, and in this he had bad fatigue, and because he was weaning off prednisone, we wanted to support those adrenals. And then we followed the prescription antibiotic by a high-dose berberine for 4 to 6 weeks to maintain that remission of the bacterial overgrowth. And we also gave him Saccharomyces boulardii during the antibiotic treatment to prevent antibiotic side effects. So he finished the antibiotics and berberine and absolutely symptom-free. And we continued his basic regimen, probiotics, glutamine, and the multivitamin, vitamin D. He was feeling great, gained 10 pounds back, and he was an active theater student and was doing fantastic. So just a couple slides on that. IBD can be caused by dysregulated immune response. So this can be normal, like probiotic types of bacteria. It could even be lactobacillus species or anything of the sort. And the problem is the genetic predisposition towards dysregulated immune response in Crohn's disease. So as we know the triad from Dr. Vasana, we have to have 3 things present, and that would be the genetic predisposition, the environmental trigger, in this case a bacterial overgrowth, and then a leaky gut or intestinal permeability. And the importance of this is that those microbes can regulate that immune balance. And if there's a sway to the side of Th17, there's a predisposition towards autoimmunity. And many of these patients will have more than one autoimmune disease. They might start out with Hashimoto's and develop inflammatory bowel disease or develop other things even as serious as MS. This is just a simple picture showing that progression. This, as you can see, those little colored rods on the top are representing bacteria, and but it's all commensals. They're all happy, normal probiotic bacteria, so there's no overgrowth or infection. And in this case, the body is more predisposed to higher Treg cells, the ones you see at the bottom in the green, and there's less risk of autoimmune disease when you have plenty of Treg cells. The problem comes when you go towards this way, when you have pathogens that are triggering that Th17 response, which causes more predisposition towards autoimmunity. And even though it fights infections, the patient is more prone to that. And these differences in the commensal composition, they change that from either Treg predominance or Th17 predominance. And this mucosal immune response is either one of tolerance or the stimulation of the immune system. I mentioned IL-10 because a lot of people have genetic SNPs with IL-10, and they're going to be more prone to upregulation of the Th17 response in TGF-beta and IL-6. Just another picture of that. Okay, last case tonight here. This is a 31-year-old female with lupus who presents with chronic constipation, heartburn, and abdominal pain. She has a history of migraine headaches, sleep issues, depression, and anxiety. She craves sweets. So why do I mention that? I always ask patients, do you crave sweet or do you crave salt? And very often, if a patient has a pretty intense sweet craving, there's dysbiosis in the microbiome that's driving that sweet craving, either fungal or bacterial. And I often ask, as patients are healing and recovering from dysbiosis, the cravings go away. So that's another way you can tell you've cured them or you've healed their gut, is when the cravings are gone. She has a history of bipolar depression, narcolepsy, lupus, migraines, insomnia, constipation predominant, IBS, GERD, and Raynaud's. So a little bit of autoimmunity here, mood disorders, and again, the gut and the brain and the immune system are so intricately connected. These are very common presentations that we see. So her culture was positive for Candida in the stool, and typically if I see any Candida in the stool at all, even the 1+, I'm concerned about it being an issue. And the other important thing is there's very many times when there's not a lot of Candida in the large intestine, but it's more in the small bowel or other places, sinuses. So you can miss fungal dysbiosis on a stool test if that's the only test you're relying on. And that's very important. I will often do Candida IgG, IgA, and IgM in the serum, which will tell about systemic candidiasis if those are positive. And I will often do organic acids like the one I showed you in the previous test, dearabinitose, to also show another marker in the body. And by doing those three, it's less likely that you will miss a diagnosis. This was the sensitivity and specificity. And here is what I just mentioned, the 3 ways that you can check. You can do a stool profile culture, you can do urinary organic acids, and there's more than just arabinose on certain test profiles. And then you can check for immune response in the serum, and I often do all 3 if I want to be sure that I'm not dealing with fungal dysbiosis. Now, one caveat to this that I think is incredibly important, listen up. Probably one of the most important things that I've learned with fungal dysbiosis is this doesn't happen in a vacuum. So if you have a patient where you suspect or you find markers that signify fungal dysbiosis, you always want to ask the question why, because typically yeast is opportunistic, so the patient could be immune compromised. And the ways you can check that are you can do IgG, IgM, IgE, and IgA in the serum. You can do subclasses of IgG and check for immune deficiency, selective IgA deficiency, and other immune issues that would predispose someone to fungal overgrowth. You want to check for infections like HIV that would suppress the immune system. And you want to check for toxic exposures like chemicals, pesticides, and mold, which can all contribute to contribute to suppressed immune system. And the importance here is that once patients are colonized and they often switch from this typical normal form into the hyphal form, which is much more invasive and can actually go into the systemic system. And as I mentioned before, Th17 is a big player with autoimmunity, and there's many studies that correlate Candida as a thing that predisposes patients to more Th17 upregulation and thus autoimmune disease. So basically in this study, the Th17 pathway was upregulated through candidiasis. And then some studies show that Candida has a similar sequence of proteins and may be a predisposing factor in the development of celiac disease. So if you have a new onset diagnosis of non-celiac gluten sensitivity or true celiac disease, you want to check for fungal dysbiosis and treat if present. Symptoms, very commonly fatigue, that spacey brain fog, either excessive fatigue or trouble sleeping, anxiety, mood swings. I would say with Candida, I more often see constipation versus diarrhea, but either can happen. I frequently see depression, anxiety, mood swings, irritability, blood sugar instability. The alcohol intolerance comes because Candida produces acetaldehyde, a chemical byproduct of the metabolism of yeast, and that particular metabolite is very similar to formaldehyde and needs to be detoxified in the liver. When you drink alcohol and have a hangover, it's the same acetaldehyde that gives you the hangover. So these patients are literally hungover from the products of the yeast. Treatments can include medications or herbs, and I use both depending on the patient in combination. Typically a 2-week regimen will not cure them. You need to be on whatever regimen you choose for sometimes months. I typically do not use the azole types of drugs, fluconazole, itraconazole, ketoconazole, for longer than 30 days. And if I am using them, you absolutely want to use milk thistle or silymarin to protect the liver. And this was just an interesting study talking about food. Coconut oil-rich diet lowered the colonization of Candida versus tallow or soybean oil. So you can use foods like coconut oil in the patient's diet, MCT, in their coffee, which is a favorite of mine, and lower their risk of colonization as well. And then this is just a fascinating article by NPR, and they did a CBS special on it as well, of something called auto-brewery syndrome, where if you have fermenters, these could include types of bacteria or fungal in the small bowel, you can actually have fermentation occurring where you produce alcohol in your guts. And these are the main fermenters: Enterococcus, Streptococcus, and Candida. This just shows and proves that it can happen. You can make alcohol from the yeast in your body. The interesting thing about that auto-brewery syndrome is patients can have blood alcohol contents with no consumption of alcohol based on their gut microbiome. So it's pretty fascinating. If you look into these studies, they show, I think the first case was a drunken man on a bicycle that got pulled over, and he hadn't been drinking, but he had a blood alcohol above the legal limit, and it turned out to be his gut was the culprit. So I just find that a little bit hilarious and also fascinating. And these are just reports showing that Saccharomyces cerevisiae, we think of that brewer's yeast as not a big deal, but it's very different from the Saccharomyces boulardii that we give as a supplement. And some of the most sick patients with inflammatory bowel disease have the largest colonization of the Saccharomyces cerevisiae, and it can be very, very problematic. So don't ignore that. It can be a significant pathogen. And then lastly, I just wanted to tie in again the Candida autoimmunity. MS in this study was aggravated by Candida, so any sort of autoimmune disease you're going to want to look at the gut and rule out either small bowel overgrowth or SIFO, small intestinal fungal overgrowth. Okay, so that is the end of the cases. I would love to open it up for questions.
Great, thank you so much, Dr. Carnahan. And as the questions come in, please use your chat button. I wanted to highlight the 24th Annual World Conference. The pre-conference workshops will kick off the 24th Annual World Congress in Hollywood, Florida on May 19th through the 21st. The Good Gut, presented by Dr. Jill Carnahan, Dr. Andrew Heyman, and Dr. Aristo Vojdani, will be back by popular demand on Thursday, May 19th. You'll have the opportunity to learn from the experts, engage with the faculty, build your therapeutic toolbox, as well as earn CME. Dr. Carnahan, I have a question that is regarding the first case. Dr. Carnahan talked about calprotectin less than 50. What does that mean again? Is it progression of disease?
Okay, excellent question, and because I actually quoted that patient's number wrong. It didn't really matter in the end because it was high, but calprotectin is very significantly correlated in the literature with flares of Crohn's and colitis. So if you're doing a stool profile, you'll often see calprotectin, sometimes lactoferrin, and sometimes eosinophilic protein X and SIGA. Those are 4 of the inflammatory markers. The big deal, the red flag is what I call it, is calprotectin. So what that means is if you see, for example, you have someone who has IBS type of symptoms, either IBS predominant diarrhea or constipation, and you want to know, does this patient need a scope? Do you think they have inflammatory bowel disease? Calprotectin can be your best friend, because if that calprotectin is elevated and the cutoff is above 120, above 200 is definitely high, but if anything above 120, and you start to have concern even above 50. So 50 to 120 would be moderately elevated, and then above 120 would be definitely on the high side. And what that means is that patient is either in a flare of Crohn's or colitis. It could be a cancer condition, or it could be some other significant inflammatory condition. So when you see calprotectin above 120, you want to have that patient have a scope if they haven't, and make sure that you're not missing something significant like Crohn's, colitis, or cancer.
Thank you. Dr. Carnahan, have you seen Crohn's patients decompensate on glutamine? What are the glutamine doses used, and for how long?
Okay, this is another fantastic question. So L-glutamine is a precursor of glutamic acid and of GABA. So our body can do multiple things with that. It is also the fuel for the enterocytes. So if you have microvilli damage and inflammation, it can be a very helpful thing to heal those damaged microvilli. I typically will start with 3 grams and go up to 10 grams. I usually do not go higher than 10 grams. Now there are some other doctors out there that will say that glutamine can never be an issue with someone with seizure disorder or glutamic acid toxicity or brain inflammation. I disagree with that, and I feel like patients who have a predisposition towards excess glutamic acid, patients that may be super sensitive to MSG, which is a glutamic acid antagonist, and anyone with any sort of neuroinflammatory condition, I would be very cautious and I would avoid the use of glutamine. I have seen patients get very agitated, insomniac, and irritable on glutamine in that case. One way that you might know that if the patient didn't have something like a seizure disorder would be to check quinolinic acid in the urine. That's a part of most urinary organic acid profiles. Again, that's quinolinic acid. If that is high, there's usually inflammation in the brain and it's neuroexcitatory, and I would be worried about starting a patient like that on glutamine. Your typical Crohn's or colitis or IBS patient that you wanted to use glutamine, I would say an 80 to 90% can tolerate just fine. So it doesn't mean that you can't use it in most people, it just there are some cautions.
Great, thank you so much. If anyone has any further questions, again, please use your chat option. Dr. Carnahan, while questions are coming through, would you be able to provide us a little bit of insight what will happen throughout the day on the good gut?
Sure. So it is going to be a fantastic day. Dr. Vojdani will be there, who is one of my heroes on the immune system and gut connection, and he's done so much incredible research, and I just always enjoy, even if I've heard his talks before, I always enjoy hearing him again. And you're going to hear all the basics from how do you start to test the gut microbiome, and what do you do with that data. So I will go through, I think, an hour and a half or 2 hours of just how do you use the data that you can collect on these patients. And then we'll take some time and go into the immune and gut connection, because as you heard even tonight, there's a profound connection between the gut, the dysbiosis that occurs in the gut, and the predisposition towards autoimmune disease, inflammatory conditions, even things like heart disease, dementia, aging, and I'm going to touch on all of those. And some things you might not know that I'll be teaching on will be the specific types of strains of bacteria that can predispose people to things like high blood pressure. Who knew, right, that the gut microbes could cause high blood pressure? But they can, and I'm going to present things like that you maybe haven't heard of before on the microbiome and the connection between all kinds of different diseases. So we'll talk about the testing, we'll talk about the autoimmune connection, and then just some practical cases like the ones tonight as far as how do you take this into clinical practice, how do you start treating your patients. And of course, we'll leave lots of time for Q&A, so it'll be a real practical type of day for you.
Thank you, Dr. Carnahan. I have another question for you. What is your favorite way to check for parasites? We often see patients who are worried or high risk, but it is hard to see these organisms in a culture.
Yes, whoever wrote the question, absolutely, you are right. I find that to be the most evasive of diagnoses. So our typical stool profiles that I use, I would say they're not great at assessing parasites. They're good, but they're not great. And as we know, parasites can be in other places besides the colon. And when we're doing a stool test, we're really assessing the colon. So you could have parasites in the small bowel, you could have parasites in the pancreas or the gallbladder, you could have parasites really anywhere in the body. Sometimes they can be missed. One doctor once told me, you know, I don't have validation on this as far as a trial, but that parasites were more active around the full moon. And as crazy as that sounds, I do usually advise patients to do their testing. We do 3 days instead of 1 day if we're looking for parasites. I often, if they're constipated, you're not going to get a good result, so you want to give them either some magnesium citrate or vitamin C to encourage either normal bowel function, or even a little bit on the loose side is better, sort of a purge. And then I usually have them collect around the full moon of the month, just because of that activity may be enhanced during that time of the month. And again, those are just some clinical things that seem to give better results. But it can still be tricky. There are some specialty labs that all they do is parasitology, and on occasion I've used those stool tests so that we can look specifically, and those are usually microscopy. Some expert will look under the microscope and tell you what they see.
Thank you. Dr. Carnahan will maybe address one or two more questions before we get to those. I just want to let the webinar attendees know that we do have a special 3-day package for you that will save the A4M members over $500 in savings for the 3 days. That's inclusive of the workshop and the World Congress. And for the non-members, a special rate that will save you over $800. And getting to the final questions, Dr. Carnahan, are you using IgG product or like product?
Oh, these are such great questions. I love it. So yes, what I would say is right now I don't know any commercially available IgG products that work that don't have a dairy base. Colostrum, IgG, or any sort of, there's even a new liposomal IgG out there. So I do use those. I find those incredibly helpful because part of this, like we mentioned with the Candida case, these are cases of weakened immune system. So first, before you just start to treat that, you want to ask the question why. Why is the immune system weakened? Is it a toxic overload? Is it a mold exposure? Is it a infectious disease? And what else is going on? And you want to assess that. I often will add those products as long as a patient tolerates it, but a lot of these patients don't tolerate any dairy whatsoever. So in those patients, we can't use an oral colostrum or IgG. However, IVIG is also an option because I'm not an immunologist. I don't use that in clinic, but I do work closely with an immunologist here in Denver. And on the really sick patients who aren't getting well, that IVIG can be a huge Band-Aid. I don't feel like it's a cure, but it can be profoundly helpful to the patients with a weakened immune system.
Thank you, Dr. Carnahan. For the patient with Crohn's disease, what maintenance plan did you keep him on once in remission, and what are the long-term results?
Yeah, so he's still doing great, and this is a year and a half after the treatment. And I kept him on basic. Now he's an 18, maybe 19-year-old kid. So as you know, with those ages, you can't get them on a lot of supplements. At least with this guy, he's active. He's in theater. He's going to college now. So I try to minimize it, but I feel like vitamin D is essential. Probiotics, absolutely essential. A multivitamin in that case. Interestingly, I'm not usually a huge fan of multivitamins. I'd rather do individual targeted supplementation, but for a kid like that, it's a great way to get him the basics that he needs. I did have him on glutamine powder for about a year, but I don't use that long term, so he's no longer on glutamine powder. And again, I'm going from memory. I think we had for probably at least at 8 weeks and possibly longer, we weaned off the berberine. So I had him on berberine for probably a total of 6 months at some dose. And we don't have him on any other antimicrobials currently. I think what else he's on right now. That might be it. It's pretty basic. He does follow the SCD diet, and I also credit part of his remission to just his good, healthy eating habits.
Okay. Dr. Carnahan, do you mind one last question?
Sure, no problem.
Oh, okay. Do you test for interleukins? If so, what lab do you use?
Oh, good question again. So different cytokines they can be really tricky because most labs don't have the good technology to really get accurate results. Here in Denver we have National Jewish, and they have some cytokine panels and stimulated cytokine panels. So if I'm checking, what I usually do is a stimulated cytokine panel. I don't know if that's available to other people across the United States, but I use National Jewish for that. I think Quest will send to National Jewish, and possibly your labs would send here as well, because it just happens they're in our backyard, but they're a leader nationally for these cytokines and things. And that stimulated panel will actually check your baseline, and it'll check a kind of neutral bacterial antigen and a candida antigen. So you can kind of see what part of the immune system is either stimulated, upregulated, or downregulated. And it does a whole panel of TGF, beta, IL-10, IL-2, IL-6, IL-1, and you can see the reactions in those panels. I will say I don't do that frequently. It's not a baseline lab, but in the complex cases I sometimes go to with that.
Great. Well, thank you so much, Dr. Carnahan. We're so excited for your upcoming workshop. If anyone would like to register tonight, please give me a call. My name is Lindsay. My direct line is 561-777-6807. I can send that offer for the special 3-day rate this evening. And again, this is Lindsay, 561-777-6807. Thank you so much, Dr. Carnahan, for your time tonight. We truly appreciate your expertise, and we're so excited for the workshop.
Thank you. Looking forward to seeing some of you there. Good night,
Thank you. Good night.